Thank you for joining us today for our Recognizing and Treating Anaphylaxis, Why Epinephrine and Why Not Benadryl webinar. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and today our guest speaker is Dr. Wade Watson. Before we get started, I'd like to note a few housekeeping items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions upon registration. The format of today's session is a bit different than previous sessions, as we're going to put forward several reaction scenarios, and based upon these have been based upon questions that you've submitted. And we're going to ask you for your feedback on what you would do with each of these scenarios. If you do have questions throughout or need some clarification, please do submit them in the question box throughout the webinar, and we'll try to address as many of them as we have time available. This webinar will be recorded and shared on foodallergycanada.ca afterwards. Let's start with a little background on this session. For all of us managing food allergy, we can all relate to the steps we take on a daily basis to avoid our allergens and are concerned about accidental exposures and a potentially severe reaction. The fear of anaphylaxis is real and anxiety producing, and one of the best ways to manage that fear is by building our confidence in recognizing and treating anaphylaxis. This has been our primary focus during Food Allergy Awareness Month in May through our Know It, Treat It campaign and our educational programming. We are continuing along that effort with today's interactive session where you can learn and test your knowledge with our expert, Dr. Wade Watson. Dr. Watson is a professor of pediatrics at Dalhousie University, head of the Division of Allergy at IWK Health Center, and the chair of the Specialty Committee, Clinical Immunology and Allergy for the Royal College of Physicians and Surgeons of Canada. He's also a member of our Healthcare Advisory Board. So we have the expert here to guide us on this topic. So here's the format. Dr. Watson will start off the session with a few slides, providing an overview of anaphylaxis, signs and symptoms, and its treatment. And then we're going to turn our cameras on, or I'll turn my camera on, and I'll present a number of scenarios to Dr. Watson. And then I'm going to ask the audience, the viewing audience, via poll, whether they're going to treat that particular scenario with epinephrine or not. Then we'll turn it back to Dr. Watson to share his expert's view and the corresponding rationale behind that. It's a real opportunity for you to test your knowledge and build your confidence. So I'd like to ask Dr. Watson if he would turn on his calendar, and I thank him for taking his time today out of his busy schedule to be with us and guiding us through this topic.
Wonderful. And thank you, Jennifer, for that introduction. I do suffer a little bit from the imposter syndrome. So every time I'm introduced, I'm not quite sure who they're talking about. But anyway, so it's my pleasure to be with you for the next hour. And as Jennifer had mentioned, this is the topic. The overall goals, hopefully, is by the end of this session, the participant, be empowered to respond to suspected anaphylactic reactions and be confident about your decision to use epinephrine. The learning objectives is that by the end of this session, you'll be able to review the signs and symptoms of anaphylaxis, describe the reasons for epinephrine being the first-line treatment for anaphylaxis, discuss the role of Benadryl or other antihistamines in the treatment of anaphylaxis, discuss the importance of early recognition and treatment of anaphylaxis, and more importantly, as Jennifer had mentioned, use cases to improve your comfort level with managing possible allergic reactions. There are really two key messages that we will be reviewing throughout this session. If you think an allergic reaction is anaphylaxis, use epinephrine, and you will not cause any serious harm by using epinephrine. So from a medical point of view, anaphylaxis is a serious, undesirable reaction produced by the immune system. It comes on quickly and unexpectedly, and I think as everybody worries, it may be life-threatening. So the World Allergy Organization in 2020 tried to simplify the anaphylaxis diagnosis and come up with two situations that would be considered anaphylaxis. So situation one is acute onset of an illness, either minutes to several hours, and by most convention, it's 2 hours, where you have involvement of the skin and at least one of the following. So you have skin plus either airway or breathing issues. You have circulation issues such as low blood pressure or other end organ dysfunction, such as collapse, syncope, incontinence, or you have skin symptoms plus severe gastrointestinal symptoms. So crampy abdominal pain, repetitive vomiting. So that would be one definition. So there's not an obvious exposure to an allergen in this situation. So that's why skin plus one other system. Or you get acute onset of hypertension, so low blood pressure, or bronchospasm, so lower airway involvement, cough, wheezing, shortness of breath. Laryngeal involvement would be stridor, have trouble breathing and getting air into your lungs after known exposure to either an allergen that you know that you're allergic to, or a probable allergen for you. So it is either blood pressure issues, bronchospasm issues, or laryngeal involvement. And again, I'd like to simplify that from the point of view of you as the public. So it's a sudden onset, minutes up to 2 hours, and either symptoms for two or more body systems. So you've got skin, respiratory, gastrointestinal, or cardiovascular, or one severe symptom with known ingestion. So either, like for example, eating peanut butter, you have a sudden hypotension or difficulty breathing. And it's important to remember that hives do not always appear during anaphylaxis. The issue about smell versus inhalation. So it's the protein in food that causes an allergic reaction. And food odor, such as smell of peanut butter, there's no protein in that. So that just should not trigger any reaction, except that, certainly if somebody smells something to which they're allergic, it may make them feel anxious or uncomfortable. And sometimes that's misinterpreted as respiratory symptoms. But smelling a food odor is not the same as inhaling airborne protein. So, for example, if fish is being fried in a home, there are small airborne proteins of fish that are in the air during the frying process, and that can be inhaled and trigger symptoms. And important to remember that not all anaphylaxis is life-threatening. So you can have mild symptoms, which responds quickly to treatment. You can have severe wheezing or stridor. And then again, the worst thing that everybody worries about is respiratory failure, plus or minus low blood pressure, plus or minus loss of consciousness. But many times the symptoms do not get to that depth. I just wanted to review the effects of medications in anaphylaxis. So if you look at the body system and the impact of epinephrine versus an antihistamine such as Benadryl, with regards to breathing issues, epinephrine opens the airways. With regards to circulation, epinephrine raises heart rate, raises blood pressure, increase heart contractions. So if there is issues with regards to low blood pressure, epinephrine is very effective. From the immune system, it stops ongoing reaction. So epinephrine is the most potent stabilizer of the allergic cells called mast cells. And for the skin, epinephrine does reduce hives. When we're talking about an antihistamine such as Benadryl, the only thing that the Benadryl is going to do is reduce hives and perhaps make you less itchy. In anaphylaxis, epinephrine is quite effective. There's a better response if it's used early. Then the side effects are really mild and disappear rapidly. So you may feel your heart beating in your chest. So you're going to increase heart rate. The skin gets pale because of constriction of the vessels. You may feel shaky, and it actually can trigger some nausea. So Benadryl and allergic reactions, as stated before, it is an older antihistamine, and it does cause drowsiness. So Benadryl is able to cross what we call the blood-brain barrier, and interestingly, it has the same brain activity as a blood alcohol level of 0.1. Not that it contains alcohol, but it has the same impact. So in an emergency situation, when you're trying to assess level of consciousness, Benadryl may interfere with that. And as I said, I have a little toddler here with their martini glass. So as I explain to families, one dose of Benadryl is like having one martini. This slide just indicates which epinephrine auto-injectors are currently available in Canada. So the EpiPen on the left and the Allerject on the right. And there are two doses, so 0.3 milligrams and 0.15 for both. So I wanted to review a decision tree, and I'm going to use that for the cases that we're going to discuss. So obviously in the decision is, if you're seeing some symptoms, is there a potential exposure to a known or potential allergen? So the question, you need to be able to answer that question. Is the answer yes, no, or you may be uncertain? The next decision is what I'm seeing anaphylaxis? And we review the definitions for you. So I'm going to go through several potential scenarios. So if the answer is no, then important that what you do is you watch closely, because you want to see if there's any change in symptoms. If you're watching and all of a sudden you feel the answer is yes, that by definition epinephrine is the next treatment of choice. And then there's always that uncertain point. If you're uncertain that what you're seeing is as anaphylaxis, my advice would be to use epinephrine. As I said before, it's not going to cause any significant harm. And if you're watching closely and you become uncertain, the issue is I would recommend using epinephrine. So again, asking the question is, if what I'm seeing anaphylaxis? If the answer is yes, the next step is to use epinephrine. And again, if the answer is I'm uncertain, my recommendation would be epinephrine. So if you look at the decision tree, really what you need to ask yourself and try to answer is, what I'm seeing either within yourself or with your child anaphylaxis? And you've got a no, a yes, and uncertainty. Then you follow through with the advice that I've given you. I'm just going to break here momentarily for questions, and Jennifer, I will keep my computer on full screen, so
Perfect.
I rely on you to see if there's any questions up
Okay.
until this point.
We don't have any questions right at the moment, but we're going to, some of the pre-submitted questions we've already embedded into the cases. So why don't we move to the first case? Okay.
Absolutely.
Perfect. So here's the scenario that I want our audience to consider. So we've got an 8-year-old boy with a sesame allergy who experiences a one symptom reaction after a snack. So that's a rash or a tingly tongue or an itchy skin. Now, this is where you all need to get ready to answer a poll, because we're going to ask you here, given this scenario, would you give epinephrine, not give epinephrine, or are you unsure? So let's see what our viewing audience is thinking about this situation. Just give it a few minutes. There's lots of activity taking place here. It's good to see the engagement. This is how we learn. All right, so we've got 36% said yes, 50% said no, and 14% unsure. So now I'm going to turn it back to Dr. Watson to give the expert perspective on this scenario and walk
Great.
us through the rationale.
Great. Thank you, Jennifer. So again, I'm going to use the questions and the decision tree that we discussed. So, I mean, I think the big question that you need to ask yourself and find an answer is, there potential exposure to a known or potential allergen? So in this situation, the issue was sesame. And again, I mean, if there is the ability to check the label if possible. So, either when you check the label, it's either going to be yes or no, or you still may be uncertain because you may not have a label to look at. So then the next question is, what I'm seeing anaphylaxis. And if we use the definitions I just discussed with you, I would not consider this anaphylaxis. It's either one system involved, and you either have itch, you have some discomfort or tingling. The important thing is that you would watch this child closely, and the question is this time to use perhaps a non-sedating antihistamine to help to relieve the symptoms that this child has?
Okay, so in this scenario, I mean, let's just dig a little bit into this antihistamine question, because I think this is a good example. There's lots of people in the audience who have used Benadryl. They've found it to be helpful to them, and they haven't experienced anything that's a problem, at least not to what we're hearing from the questions that have come in. So can you just restate sort of some of the concerns around the use of Benadryl?
Sure. And I will also say that the Canadian Society of Allergy and Clinical Immunology, which is our professional organization, put out a statement a few years ago with regards to Benadryl or other sedating antihistamines. The bottom line is everybody hears do the drill. I mean, it's very good from a marketing point of view. It's sort of like a tissue. I mean, everybody doesn't say tissue, they say Kleenex because of marketing. But in this situation, Benadryl is one of the oldest antihistamines, and it's its ability to cross the blood-brain barrier and its ability to cause sedation that we worry about as an allergist. So there are lots of non-sedating antihistamines, and there's Arius, there's Claritin, there is Reactine or Cetirizine. There are new ones by prescription that Rupatadine and Bilastine. So they're just better. There are better choices to
Right.
use. And since they're available, most of them are available over the counter, my advice is to use something that works better and has less potential for adverse effects.
Okay, and then so given that it doesn't have the second generation, don't have the sedating effects, would patients be or families be comfortable in if they're using epi and also using an antihistamine at the same time? Like, is there a problem with that?
Well, there isn't, as far as using an antihistamine. One of my experiences with families that I've seen, using the antihistamine does not give them permission to stop watching either themselves or their child. And I just worry that, I mean, if the symptoms are mild and just skin, they're uncomfortable and they're monitoring for presence of other more serious symptoms, sure, using a non-sedating antihistamine would be fine. It's just that they need to continue watching and looking
Right.
for other symptoms. And that's sort of the big thing.
So don't kind of go, I've treated this. It is really that what you've got on the slide there. Watch closely.
Yeah.
Yeah,
And again, it's because an antihistamine will not prevent any further progression of potentially respiratory, cardiovascular, or stomach symptoms. So the antihistamine is just going to relieve the itch and discomfort, but it's not going to stop the other symptoms. So you need to keep an eye on things.
perfect. Okay. All right. So let's go on to the second case. Okay. And in this case, what we've got is an 11-month-old baby with an egg allergy who's having breakfast and hives start appearing, quickly covering a large part of her body. Let's put it out to our audience. Is this a situation where would you give epinephrine? Yes, no, or unsure? All right, we're getting close. Okay, we have 24% saying yes, 60% saying no, and the remainder unsure. Back to you, Dr. Watson, to walk us through this scenario and the rationale for treatment.
Great, thank you. So the big question that I had when I looked at this, the first question is there any egg served at breakfast for the family? I mean, you certainly, uh, if the answer is yes, then my suspicion for an allergic reaction is certainly much higher. If there's no egg there, then you have to say, well, what's going on? So that's my first question. But then, if what I'm seeing is anaphylaxis, so you've got generalized hives, the answer that in my mind is no. However, I mean, this is somebody, again, you've got a young child, it is breakfast. Is there some potential egg there? I'd watch closely for worsening. And then in this situation, I would really, I mean, since the use of antihistamines is not going to prevent a more severe reaction, I would be much preferable for the family to keep an eye on this child to look for any presence of other symptoms. So I would hold off on the
Okay.
antihistamine until I was confident there was nothing else progressing.
Okay, so let's kind of adapt the scenario based upon one of the questions that came in around this two symptoms. So let's say we had kind of mild hives and a stomach ache. Now, I'm in an 11-month-old. Admittedly, that would be hard to. Maybe we need to change the age of the child because I'm not sure at 11 months you're going to get feedback on a stomach ache. But I think there's some questions in the audience around how do you think about what's a mild symptom, and this kind of whole too mild symptoms. Like how do you guide on that one, Dr. Watson?
Well, again, it depends on, first of all, it depends on the comfort level of the family. So,
Right.
I mean, let's say there's four hives and the child's sneezing. One
Yeah.
sneeze, two sneezes. Again, I mean, you're not seeing anything that is severe. As long as you're watching closely and see if there's any worsening of symptoms, then I think that that's safe to watch. Now, one of the things, especially when I do food challenges in my clinic, I sometimes get children that have three or four hives, but they have uncontrolled crying, and they're crying, 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 and cannot be consoled. And it's very interesting. I don't know in young children if that's a marker for perhaps abdominal pain. Certainly, even if you've got a few hives, but you really have uncontrolled crying in the child, I certainly have used epinephrine in my clinic, and it's fascinating to see those symptoms improve. The bottom line is, I think it's going to rely on your comfort level. If you're not comfortable with hives and say there's sneezing, then there's no reason why you can't use epinephrine in that situation.
Okay. Okay. Let's go on to the third scenario. So, in this scenario, we've got a 34-year-old man who's experiencing abdominal cramping, hives, and wheezing after an evening run. And he'd eaten grilled shrimp at dinner that night. What is our viewing audience's opinion on this? Would you give epinephrine? Yes, no, or unsure? All right. We've got 70% saying yes, 9% saying no, and 21% saying unsure. If you can walk us through this scenario, Dr. Watson.
Sure. So the big thing that came to mind when, is there potential to a known or potential allergen? So again, the answer is yes, no, or uncertain. But in this situation, is there a cofactor increasing the risk for anaphylaxis? So this gentleman went out for a run after eating shrimp. And, there are food associated exercise induced anaphylaxis where exposure to fresh fruits, fresh vegetables, seafood, wheat, 2 hours, within 2 hours of exercise can be a trigger for anaphylaxis. So is what I'm seeing anaphylaxis? Certainly by definition, the answer in my mind is yes. And so epinephrine would be used in this situation. The other thing in this situation is this gentleman needs to see someone to have confirmed that it is food and exercise. And then we recommend, that you avoid exercise either. I always get this confused because I see so few of them in children, but you would want to avoid exercise for at least 4 hours after eating, or you want to avoid eating at 2 hours after exercise. And I think those are the numbers, but I'd have to look them up.
And sorry, I just had a question come in on that. Is there a technical name, or is the technical name for this exercise-induced anaphylaxis? Is that
It's food,
some?
food associated exercise induced.
Okay. Wow. Sounds like we need an acronym for that one, Dr. Watson.
I'm
Food
not,
induced exercise.
so food
Sorry.
associated exercise induced.
Got it. Okay. Got it.
Okay.
Okay. Perfect. Okay. Let's move on to the next scenario. Okay. In this scenario, we've got a 13-year-old girl with allergies to peanuts and tree nuts. There's extreme vomiting, cramps, and possibly diarrhea, and extreme stomach ache and nausea after having a drink at a cafe. Let's ask our viewing audience: is this a situation where you'd give epinephrine? Yes, no, or unsure. All right. Okay, we've got over 80% saying yes, 3% saying no, and 15 unsure. 15% unsure. So back to you, Dr. Watson, on walking us through this one.
Okay, thank you. So the big thing again is that is there a potential exposure to a known or potential allergen? And again, the ability to look at labels is very helpful, but you may not be able to. So I mean, the question is, if this patient is tree nut allergic and there are nuts served at this cafe, then the answer is you probably have a yes. Now, even though it's one symptom, it certainly is severe. So by definition, I mean, I looked at this, I was uncertain, but given that situation, I would use epinephrine.
Okay, let's uh, take a couple of minutes to talk about epinephrine safety, because there are some perspectives that epinephrine, when it's not an anaphylaxis, could in fact be harmful. Can you walk us through some background on that and help to dispel that myth that exists out there?
Well, the bottom line with epinephrine, I mean, we constantly are producing our own epinephrine during our what we call flight or uh, fright and flight reactions. That what we the feelings that we get if we're scared or you see a bear in the woods and you want to run. I mean, you're producing your own epinephrine, which is going to give you the ability to run faster, hopefully, than the bear. But more importantly, so if epinephrine is not required, you might get some pale skin, your blood pressure may increase slightly, you might get a headache, and you might feel slightly nauseous. But as far as causing a severe reaction, I mean, it really doesn't happen. And over the course of my career, I've had trainees and nurses who have mistakenly given themselves active epinephrine when they're demonstrating, usually in a public forum, because they didn't realize they didn't have a trainer and they had the real thing. I mean, those are the symptoms that you're going to have. You know,
Right.
certainly I would say, I mean, if you were 94 and had recurrent strokes and, you know, using epinephrine in that situation, you know, like, I mean, you have to balance it out. But if you don't need epinephrine and you use epinephrine, the potential for causing any serious adverse effects um, are negligible. Now, having
Okay.
said that, the only situation I've had patients who injected themselves with epinephrine into their thumb, you know, and because they had the auto injector, especially the EpiPen backwards, that's the sort of situation that is a potential dangerous because it's a potent vasoconstrictor. So if you have all your vessels in your thumb vasoconstricted, that could be a potential problem. But again, you've inappropriately have administered epinephrine in that situation.
Okay. Now, on the question around the different devices, is there a difference? And we had this question come through in advance as to whether there's a difference in the efficacy of the auto injectors that are available.
No, they both administer the same epinephrine. There are
Right.
slight there are slight differences. I mean, the EpiPen is older, so people are much more comfortable from a technical point of view. The allergic auto injector, I mean, it does speak to you. So if you've never used it before, it certainly gives you guidelines. The other
Yeah.
thing that the allergic does that the EpiPen doesn't is that it will inject the medication in your leg and then pull the needle out versus the EpiPen, when you pull it out yourself, that needle gets covered by the case, but the needle does not get pulled out of your leg by the device. It's you pulling the device away from your leg that actually is pulling out the needle.
Okay. Okay. Now, maybe this would be a good time because we had another question just to clarify on the antihistamines. You don't need a prescription for the second generation antihistamines, correct? This is an over the counter option.
Absolutely. The
Okay.
only ones that you require a prescription for are the newer ones, rupatadine
Right.
and bilastine. But I don't prescribe those unless I'm dealing with, say, chronic hives or some other situation. But you all of the ones that I've mentioned earlier, Claritin, Allegra, loratadine, I'm running out of my names, reacting. They're all available, all in the same section at the pharmacy. So if you're uncertain, you can talk to the pharmacist, or we'll go through them with you.
Okay, great. Okay, let's go on to the next case. And I apologize, I'm having some issues with my camera. So it's turning on and off. I imagine that's somewhat distracting, so I apologize to our audience. But nevertheless, let's go on to the next case. Okay, so in this case, we've got a 6-year-old girl with a milk allergy and who wakes up in the morning with abdominal pain. Okay, so let's put this out to our audience. Let's put the poll out. Is this something you would give epinephrine? 2, yes, no, or unsure. All right. We've got 91% saying no, 3% saying yes, and 6% unsure. So, Dr. Watson, back to you to walk us through this particular scenario.
Sure, thank you. I mean, the big thing for me is there a potential exposure to a known or potential allergen? So these are symptoms as soon as the child has woken up in the morning. And if we use the criteria for 2 hours before, then, it would be unlikely that there's the potential exposure. The other thing is that it is abdominal pain. So is what I'm seeing anaphylaxis? In my mind, the answer is no, and what I would do is keep an eye on them, but I would look for other causes. To me, the most frequent cause of somebody waking up in the morning with abdominal pain, it's most likely they've come up with some sort of viral infection, or there's another trigger. So even though they have a milk allergy, there is a very little chance of exposure in that 2 hours before, because they've woken up in the morning with these symptoms.
Okay, terrific. All right, so let's go on to the next scenario. Okay, so Dr. Watson, we have a 16-month-old baby. This baby has localized hives and vomits while eating her lunch. Let's put it out to our audience. Is this a situation, a case where you would give epinephrine? Yes, no, or unsure? Okay, we've got 81% saying yes, 16% saying no, and 3% unsure. Dr. Watson, back to you.
Okay, thank you. So again, to me, I mean, we didn't really, it doesn't really say that this child has an allergy. So I guess then the question is, what did this child eat for lunch? And is there a potential allergen there? So, the typical egg, milk, wheat, soy, fish, shellfish, peanut, tree nuts. So again, yes, no, or uncertain. But again, is what I'm seeing anaphylaxis? By definition, this child has two systems. You've got acute onset of hives and vomiting. So what I would say, this is anaphylaxis. And if there's been a known allergy and the child has epinephrine, certainly that would be a thing to use. If not, so if this is a new reaction, I would call 911 and say that I believe my child is having an allergic reaction or anaphylaxis.
Okay. Okay. So, just a modification on this case, because we often get people saying, well, what about this scenario? So they like to kind of change the case a little bit. And so in this one, if it's just vomiting, like, isn't the idea that you'd want your child to vomit out the allergen?
Well, the
And
issue is, I'm sorry, Jennifer, I interrupted you.
yeah, no, and so in this case, it's kind of like if you use epi early, potentially, and would that stop them from vomiting? That's the
Well,
question.
first of all, if it was just vomiting, and like if we change the situation to just vomiting, then I'm not sure what you're dealing with, because we don't know if we have. It comes back to, is there a known or potential allergen?
Right.
So, and again, I'm not trying to waffle, but it depends. I mean, if this child has recurrent vomiting and it's severe, then certainly I would wonder, what's going on. especially after lunch, and if there was a potential allergen. If it was one vomit, I would say the answer is not anaphylaxis and it deserves to be observed. So I guess the question is, now let's say if there was a known allergen, this child had a milk allergy and accidentally got milk at lunch and started vomiting, then I would not hesitate to use epinephrine. But it's when you have one system and it's a new problem, then you have to decide, is what I'm seeing indeed anaphylaxis? So I don't mean to waffle, but it
Right,
becomes a little grayer if you're just having vomiting after a meal with a child with no obvious previous allergy. If there's
right.
nothing new or significant in their diet, I would watch.
Yes. Okay. Okay. Perfect. Let's go on to the next scenario. Okay, so in this case, we've got a 22-year-old woman who has a fish allergy, and we know she's had an anaphylactic reaction at a holiday party, and she had one or two glasses of wine with her dinner. Okay, so I think when we put this, we'll put it out to the polling audience, but I think that we there's probably more that needs to be considered that you'll walk us through. But let's put it out to folks. Would you give epinephrine in this scenario? Yes, no, or unsure? It should be 100%.
Now, don't bias them.
Sorry. Fair enough. So yes, we actually had an unsure. Fair enough, and we had 91% saying yes. So let's go through this scenario and how we might want to think about this. I feel like every time we do this, you're putting on your detective hat and walking through the question. So let's turn it back to you.
I mean, the big thing is, again, I mean, it depends what was served for dinner. If somebody has a fish or shellfish allergy and there are the things are being served, then again, you've got a yes, no, or uncertain. The thing about this particular case, and certainly it's not something I see in my pediatric population often, is the cofactor of the ingestion of wine. And it is my understanding that drinking wine actually will increase absorption into the GI tract, so that you may actually have more absorption of foods because of the ingestion of wine. So it was when I'm seeing anaphylaxis, in my mind, the answer is yes. And they need epinephrine, and they may need extended observation only in the fact that the wine may change the absorption of the foods in the system, and it may change sort of the manifestations that this patient may exhibit.
Okay. So you introduced this idea of cofactors that could change the trajectory of a reaction. What are some of the other cofactors in this situation where we were talking about alcohol, but what are some of the other cofactors that could come into play that might kind of take you to that same sort of, well, we may need an extended observation, or it could be a cofactor that makes it more severe?
Well, the three that comes to mind immediately, and one we've just discussed recently, is exercise. So I mean, there are some patients, for example, who can eat a food and not exercise and no problem, can exercise, not eat specific foods that we talked about and not have a problem. But it's that combination, eating a food and exercising with a specified period of time, or exercise and then eating the food within a specified time that will trigger a more severe reaction. The only other cofactor that comes to mind is patients with asthma. If we look at severity of their reactions because of the asthma, certainly there's an increased risk of more severe respiratory symptoms, and those patients may need to be observed for a longer period of time because of the asthma may increase the risk for more severe reaction.
Okay. Okay. Thank you. Now, another question around number of devices. What's your recommendation? So in this case, would you should this individual should they carry more than one device, or what's the recommendation or guidance in terms of the number of devices people should have?
So I routinely recommend that all of my patients have two, one for a backup. The chances of needing that backup is low, And so, certainly it's a discussion I have with families. When I'm dealing with teenagers, I just want them to carry a device. So if I can convince them to carry one, I'm happy. If I can convince them to carry two, I'm delighted. But it's a matter of, again, having that discussion with them and having them understand the reason for it. I mean, the only thing about the wine or those sorts of things is just that they may require a second device. So I routinely have them have two.
Okay, terrific. Okay,
I
let's
have.
go on.
Can I just
Sorry?
say I have some families who want five. I never turn them down.
Okay, all right. Okay, thank you. Let's move on to the next scenario. Okay, so in this scenario, we've got a 10-year-old boy with a soy allergy and asthma, has had an anaphylactic reaction, and an epinephrine autoinjector has been given. About 5 minutes pass, and now he's short of breath and says he's going to be sick. So, to our viewing audience, is this a situation where you would give another dose of epinephrine? Yes, no, or unsure? Okay, we've got 80% saying yes, 6% saying no, and the remaining are unsure. So, Dr. Watson, let's go through that scenario.
Okay. So the issue is we already know that there was an exposure. And then again, I put the issue is which we just discussed, the impact of asthma on symptoms. So if this child has asthma, it puts them at higher risk for more severe reaction and more respiratory type symptoms. And so although they've been treated for anaphylaxis, they have onset of symptoms returning within 5 minutes that are worrisome. So to me, the answer is yes. I would repeat the epinephrine. This patient, I would call 911 because they definitely need to go to the hospital for observation, and they may need extended observation in the hospital.
Okay, terrific. Thank you for that. Um, I didn't get any specific questions, but I have got some other questions that I'm going to come back to at the end that aren't specific to each of the scenarios. But I'd like to go to our ninth case. And this is kind of our final case. And then we're going to take some audience questions that have come in through the chat. So in this case, we have a 25-year-old man with allergies to tree nuts and mollusks, and he thinks he's having an anaphylactic reaction. He's considering epinephrine, but he doesn't want to go to the emergency department. Okay. We hear about this. We have people who don't want to go to the emergency department. So, do I really want to use my epi? So, let's put it out to our audience. In this situation, would you give epinephrine? Yes, no, or unsure? Okay, we've got 86% saying yes, 3% no, and 11% unsure. So, back to you, Dr. Watson.
Well, again, it's the whole issue of potential exposure to a known or potential allergen. So that's a question to ask. And if there was exposure or they're not sure, I mean, is what I'm seeing anaphylaxis? In my mind, yes. So the issue is epinephrine would be the treatment of choice. And I'm just going to go through the next slide, Jennifer, if that's okay.
Yeah, please.
So it's important that the use of epinephrine is separate from observation, but the I mean, again, we've talked a little bit about that, and if the concern is epinephrine is dangerous, you must go to the emergency department. That is not the reason why you go to the emergency department. The reason why you're going is because symptoms may continue to progress and require different therapy. And there's also concern about what we call biphasic reactions, so recurrence of symptoms after improvement despite no additional exposure. So the issue of epinephrine use should be, am I having symptoms that satisfies the definition? The going to the emergency department is, I can't think of any allergist who would not make that recommendation, but certainly that's a discussion that this patient needs to have with their allergist as to what would be the next step.
Okay. Yeah, so we did have a question on this about going to emerge. If, they've used the epinephrine and symptoms have subsided. I mean, during COVID, some of the guidance that was happening was, you know, um, people were staying at home and monitoring.
Right.
What should these individuals who are asking these questions, what should they do to resolve this question of should I go to hospital or not?
So I'm just going to come back to they need to have a conversation with their physician about their particular situations. Because in general, I mean, my concern as an allergist is that will there be return of symptoms requiring treatment? I mean, if this patient has a second auto injector, sure, you may have a discussion about that. But I think that until our allergy societies make firm recommendations, I mean, the thing, I don't worry about the 999 people who do well. I'm worried about that one person that may have recurrence of symptoms and have been reassured that they don't need to go to the emergency department. They don't have a second auto injector. They don't have access to emergency health services. So again, I think it's a it's a discussion. It is patient-centered care that needs to be discussed with the allergist as to, in that situation, what would be the criteria for them staying home and observing versus going to the emergency department.
Okay. Terrific. Thank you for that. Okay, so we're going to have a couple of other scenarios or other questions that came up, and this one sort of is around the kind of use of paramedics and sort of some of the things that people might be seeing in the emergency department. So there's a scenario that someone put forward with a peanut teen allergic, a teenager who is allergic had some wheezing and some throat tingling after drinking from a friend's glass, okay, who had eaten nuts. And, she made the decision bravely to use her EpiPen, but then the paramedics said they shouldn't have done that. They should have used Benadryl instead. So, there's this complexity of sometimes we're dealing or we're in the emergency department and we still see them using Benadryl. How do you coach the families who are in these scenarios are they're trying to do the right thing based upon kind of the their assessment of the situation, and sometimes are met with a medical community that's not seeing it their way, and it becomes confusing, right? Because you're already going, oh, should I use it, should I not use it? What's your guidance here, Dr. Watson?
Well, first of all, the scenario that you mentioned with the teenager that used the epinephrine, if I could, I would dance around my office and applaud because I think that that was the right decision, you know. And she had symptoms. There was a potential exposure. She was worried, and she used the epinephrine auto injector. My concern is that they're depending on the healthcare or the healthcare personnel that they access. They may have had a different experience. I had mentioned to you earlier before we started. I did a food challenge, and I had a very severe reaction that required the patient going to the emergency department and then to the ICU overnight. And the only reason why I mentioned it is one of the physicians in the emergency department says, this is not what's supposed to happen in anaphylaxis. You give them one dose of epinephrine and they get better. And, you sort of look at this and say, well, no, that's not always the case. So what I always coach parents, if the parents have used the epinephrine for whatever the situation, I believe they've done the right thing because, I deal with more people who do not wish to use the auto injector versus do. So that's important. And I think that the use of Benadryl or antihistamines in that situation is up to debate. The use of Benadryl specifically, there are still some emergency departments that use Benadryl as their first line antihistamine. I believe that's wrong, and our society has discussed the use of first generation. And they've had no one advocate in their hospital to get rid of a drug that is really potentially more adverse effects than beneficial. You've got better meds to use. So, I mean, I always say to the families, you do the right thing, and the people that you have accessed are wrong.
Okay. Thank you. Thank you. I think it's important for the community to hear that because people are spending their time really wanting to make sure they're doing the right things, and it's hard because when that's not validated in the healthcare environment, it can become very disappointing. Okay, so we have, I want to go back to um, skin symptoms. Okay, because we talk about two systems, but if you're in the skin, which is one system, and people are saying, okay, but I've got two skin symptoms happening. So I've got hives and I've got an itchy mouth, right? How do we think about that in terms of how you would define that type of reaction?
So to me, I mean, I always talk about symptoms beyond the lips. So an itchy mouth and generalized hives, again, it depends upon how uncomfortable and what has been ingested. So again, what is the best thing to do? Again, if you're going to be observing yourself and the symptoms are mild, using a non-sedating antihistamine for those symptoms, because you don't have, any respiratory, you don't have any cardiovascular, you don't have any severe GI symptoms. But again, if you're using the antihistamine, you still need to be aware and watching for other presence of other symptoms. If um, Again, I worry a little bit because I have a number of patients with chronic hives. When they initially have an onset, they will get hives and they will get an itchy mouth, but they've had no exposure and no previous allergic reactions to foods. So again, it really depends on the background of the patient. In that situation, is the use of epinephrine wrong? I guess it would depend upon the severity or mildness of symptoms. And again, if it's recurrent, then I would start looking for other reasons for the hives and the itchy mouth.
Okay. Now, and then with infants, that what's your guidance for parents of infants who start to see kind of the redness around the mouth? Okay, like are because we might have some people on the line that are just introducing allergens to their infants, following the guidance to help prevent the development of allergies. But what in an infant, what's a reaction look like?
Well, the redness around the mouth, I have had to use it mildly, a plethora, I mean, numerous referrals, because I think that people are being very aware, they're introducing highly allergenic foods. But again, if it's just redness and not hives, there's no swelling of lips, mouth, or tongue, the child's otherwise comfortable, then, I'm going to say 999 times out of 100, this is not allergy. And again, that would be something, if the child's otherwise fine, I think it's probably irritation from the contact of the food on the skin. I suppose, if you have actual hives, so it's raised and bumpy and it's palpable and there's any swelling of lips, mouth, or tongue, that's a very different type of symptoms or signs that you're seeing. And so certainly if it was related to peanut butter, if a child's lips became swollen and they had hives around their mouth, that's very different than if they had a peanut butter and there was a little redness or some small red dots and the child was otherwise happy.
Okay. Perfect. Okay, so Dr. Watson, we've got a few minutes remaining. I know you have some more slides to summarize kind of the key messages. So I'm going to turn it back to you, and I'm going to turn my camera off, and then I'm going to come back on. Please stay on, listening audience, because we've got some resources on this topic that will be of interest to you, as well as some upcoming events that we'd like to tell you about. And thank you, Dr. Watson, for spending your time with us here today.
Great. Well, thank you. I'll just take about 1 minute just to review things. My computer was trying to update, but I stopped it. So the key message is use epinephrine if you think an allergic reaction is anaphylaxis. I mean, if I can leave you with that one message, and you're not going to cause significant harm by using epinephrine. And if we look at our learning objectives, I hope that you being able to be comfortable review the signs and symptoms of anaphylaxis, reasons for use of epinephrine. We discussed the role of antihistamines and the importance of early recognition and treatment. And I hope that these cases will help you to be more comfortable in managing possible allergic reactions. And so, as I said, our decision tree is what I'm seeing anaphylaxis. You've got a no, a yes, and uncertainty. So if it's no, you're going to watch closely. If you're yes, uncertain, nobody will fault you for using epinephrine. And with that, that is the end of what I have, Jennifer.
Great. Well, thank you so much, Dr. Watson. We really appreciate your time. So we're going to take you through a few slides on what's next. So following this session, as everyone who has participated in the past, you'll get a short survey through GoToWebinar that asks for your thoughts about today's webinar. So please take a moment to complete that survey, as it helps us inform our educational programming and advocacy efforts. You can also register for this next webinar. This is on June 26th. We've got a theme this year focused on treatment. So on this situation, we've got Dr. Edmund Chan, who's going to speak to us about food allergen immunotherapy. You'll have an opportunity to learn about what food allergen immunotherapy is in its various forms, whether that's OIT, sublingual, which is called a SLIT, or epicutaneous immunotherapy, EPIT, where it's applied to the skin. So find out about those treatments and who they're best suited for, what they can and they cannot accomplish, and what the current landscape is for each of those therapies and what's on the horizon. So please register at foodallergycanada.ca/events. Now, it's Food Allergy Awareness Month for a couple more days here, so there's time to still get involved in our Know It, Treat It campaign and share your personal stories on anaphylaxis, specifically how you knew it was an anaphylactic reaction and how you treated it. So you don't have to have had a reaction of this degree to participate. When you share your story, you have a chance to win exclusive prizes, including a $100 gift card. And you can also share our animated GIFs and our resources, like this video that we have with Dr. Philippe Bégin. So I know there was a number of questions that people were asking about anaphylaxis, and this video is one that really gives you the science behind what's happening to your body and how it is that epinephrine delivers the best outcome. So I'd really encourage people to take a look at this, because it really is we've had a lot of positive feedback, and it gives many that light bulb moment in really understanding anaphylaxis. The other thing I would mention is that also in our FAM resources, we have some Facebook Live sessions on how to use epinephrine. And so a lot of questions that were asked today in the session are addressed in those sessions. So I'd encourage you to go and take a look at that. Just go to foodallergycanada.ca/FAM for all the details, and you'll find those additional resources. So lastly, I'd like to thank today the supporters for today's webinar. We were supported by the Schroeder Foundation, the Peanut Bureau of Canada, and also individual donors from viewers like you. So thank you for your participation in today's webinar. You can view a recording of this webinar in foodallergycanada.ca shortly. Please also share this with others who you think may benefit from this content. This now concludes our webinar.